So most welcome here. We will continue this session in English, and as you noted, there are parallel sessions right now. So I'm happy to continue the discussion from this morning on the topic of today, patient-centered care, patient centricity, which is the theme of this whole day. My name is Petra Eurenius, and I am one of the initiators, founders of FOKUS Patient. And in 2019, we thought just that the patients need to be more in the center of their care. Patients need, there's a lot of knowledge and expertise that is not used today. So this might sound simple, but it's not. So therefore, we'll continue the discussion today, showing some good examples and what needs to be done going forward. On a daily basis, when I do not work with FOKUS Patient, I'm working in the healthcare and life science sector for some 25 years with pharmaceutical companies, and today as a communications consultant with King Street PR, Ruud Pedersen Public Affairs. Let me introduce the key speakers today and participants here. Stephanie Juran, you work with the Swedish Association for Patients with Rare Diseases. And Paolo Parini, you work at the Karolinska Institute and Karolinska Hospital.
Yes.
Yes. And so we have the patient representation side and the academic research development education side. And you will talk just in a few minutes about network medicine.
Yes.
Yes. So as the topic of this session describes, when one part of the body is suffering, the whole body will suffer. Who has got the responsibility for that? So in rare diseases in particular, basically for most patients, but in rare in particular, there are a number of specific challenges, since living with a rare disease means that your symptoms may come from various body parts and may need support from various specialists. And these specialists do not always communicate, which causes trouble for patients, putting it simple.
That's exactly.
Stephanie, I'll give the word over to you to better describe this, since you are the expert. And how big a problem is this?
I will go into it in my slides a little bit, and to clarify, it's not all the patients with rare diseases that have this multiple organ challenges, but in our organizations, Rare Diseases Sweden, we have mainly people with syndrome diagnosis, thereof the results that I'm going to present. But I have got a little presentation with me. You mean like how many parts of your body? So that's what I'm going to talk about, the challenges that follow with this multi-syndrome diagnosis that many of our members have. And I come from Rare Disease Sweden, as we are talking about, an umbrella organization for people living with rare diseases. As of today, we have got 68 patient organizations with more than 16,000 members that are organized under our umbrella. Rarity is that 1 in 10,000 people or less live with just this diagnosis, because we have more than 7,000 different rare diseases known as of today. This is a large part of the population anyways. About 5% of Sweden's population is assumed to live with a rare disease today. This is as much as live with cancer. And there are a few challenges following with that. We have a lack of knowledge, because no one can know all of those 7,000-8,000 rare diseases, even in the healthcare system. More than 70% of these diagnoses have a genetic origin, so they are lifelong, and the whole family will feel the effects of it, to put it. Lots of them are multi-organ, as we already said, but there's only treatments for about 5% of the diagnosis, so a lot of the life takes about taking care of the challenges and finding solutions for how to live with it. And person-centered care, however, in theory, is a very nice approach. And we in Sweden, we have got very high ambitions. We have got the healthcare legislation that is promoting that we should have good healthcare on equal terms for the whole population. We really want to have those with the largest needs shall get prioritized access to the healthcare system. And we also say in the patient legislation that we have to ensure continuity for the peoples that need it. And reliability, continuity, and safety are very important in providing healthcare here in Sweden. And we want a healthcare system that's coordinated and fit for purpose. So we have got a very wonderful healthcare vision here, I would say. The theory is we agree as a society how we want to have it. But it's not really easy to meet all those very high standards when you live with a rare disease, which is what I will present you here today. Because when talking about patients, we are definitely talking about very different groups of individuals with very different sorts of needs. And I want to specialize this here on these four areas. Fyrfältaren, which a company called, or a leading healthcare, has been developed together with us doing a project. And regarding if you have a diagnosis that has an end or not, or if you have a diagnosis that has only one specialty involved or several specialty, you will have very different needs. Talking about the very easy one having an end and only one specialty, you will see that the individual has needs like easily accessibility, high effective and high knowledge, and freedom of choice. These are needs that you have when you have got such a kind of diagnosis. However, when you're getting chronic, then you see that continuity, being able to monitor, and self-care are very important parts. When we involve a lot of specialties, we need clear processes and good collaboration in order to meet the needs of the individual living with such a diagnosis. And if we then go to the last part, complex diagnosis, where the rare disease field lies in, then we have completely different needs, individual solutions, personal supports, and teamwork and collaboration within the system are really important parts to meet here. So when we look at a person living with a rare disease, we see that the challenges that follow around this person are very many, because you can have quite a lot of contacts at the municipality level. You will have social services, support at school, or other things that I just listed here. When you look at the state level, you can have the insurance contacts that you have to deal with. But then when you go to the regional level, of course, that is where all the many support systems lie. You can need psychological care, dental care, primary care, and all the other special areas that you can have in contact with. And if you have a lot of organs involved in your diagnosis, then you will have a lot of contacts with all those specialists and all those people also. So it's not rare that we hear our members say that they have got 60 different of such contact points. And even 200 we have heard from one, but this is the extreme. So a lot of contact points that need to be met. And here we really would need person-centered care. And we also see that the challenges in our member survey that we performed during 2022. Here we asked our members how it is to live with a rare disease, and more than 1,400 answered. 7 out of our members, as I said, do report having a syndrome diagnosis, that is a diagnosis that involves multiple organ systems. We see that only 20 out of them report having an individual care plan, that is that they would know what is the goal with my treatment and how are we supposed to go there. 6 out of 10 report having a healthcare contact, a fixed healthcare contact that should help them organize all these contacts and organize the individual care. But only 1 in 4 say that One in 4 say that they don't feel that this is a help for them, that they have other needs. So instead, 1 in 7 report that they spend more than 11 hours a week regarding administration of their care. So we have kind of a lack of coordinating structures that can meet the complex healthcare needs. And in the end, the responsibility ends up at the individual. But in order to meet this, how can we still develop towards a more person-centered care that really takes care of all these challenges around the individual? We think that collaboration and patient empowerment is really important. And this would need to occur on all levels, on the individual level, where I meet my doctor, on the organizational level, where the structures are built, but also on the system level, where the larger perspective for whole Sweden is drafted. And to be able to collaborate on all these levels, we see that we need knowledge even at our side, at the patient side, quite a lot of expertise needs to follow with if we want to be the talking partner, the collaboration partner that can help to develop the structures together. So we have developed a lot of tools, and I just want to show a few of them. On the individual level, we have got a homepage called Ward Tips, individual tips that everybody is open to go in and check it out and take some tools and to improve their own healthcare contacts. We have got on the organization level developed an education tool for advocation. This is a 1-hour education for everyone who is interested in helping us to develop the healthcare system towards the direction that we see is needed for rare diseases, where you in videos and exercises and also in open forum discussions can exchange experiences about how the structure is working that we want to improve. And also on the system level, where we have been part of the authors writing this report about how to collaborate, where both healthcare professionals, but also researchers and different patient and next of kin organizations have been part of writing this report based on both research, but also this multi-perspective that we came with. So this is a nice tool that gives you a guideline of how to collaborate, how to design your collaboration in order to make it a good way of working. So these were my points that I wanted to share with you. So as a take-home message, I just want to sum it up that we all have good intentions in Sweden. The society has really a high aim in where we want to be with our healthcare system. But in reality, there are patient groups that really have large challenges that need to be met, and this is a challenge. But we think that if we work together and we try to give our best and we try to collaborate, then we can slowly move towards a better structure for the most severe patient groups. That was it from my part. Thank you.
Thank you, Stephanie. I think needs an applause, right? I think what you're doing at the Association for Rare Disease is quite impressive. You have certainly listened into patient needs. I'm just thinking approximately how many affected with a rare disease in Sweden are members or do find this information.
Our members, we have got about 16,000 members right now. And so the information is open on our network for everybody to approach it. So, and we have got an increasing interest now. Such patient education tools are pretty en vogue. Other organizations also do it, so we're trying to reach out so that more of our members can find it and help us to spread the message.
So from the patient advocacy side, organization side, we saw great examples of listening into patient needs and developing materials. So from your side, Paolo, what are your reactions and thoughts when you see, let's say, some of the survey results showing the great needs?
But what my reaction is about time that we do that, because I usually, when I teach to new doctors or nurses, we always say that if you're a bad doctor, you cure an elevated cholesterol level. If you're a good doctor, you cure maybe a cardiometabolic disease. But if you're an excellent doctor, you cure the person that stands in front of you, because that is the goal of treatment. It's not, we have focus previously maybe in important things, but not the whole thing. So I myself say it's about time.
If to go right into one of the core, very interesting parts of the work, I imagine all of the work that you do at the Karolinska Hospital and Karolinska Institute, network medicine. Could you please give us a short description of what that is and how it can be of help for these patients and also for healthcare professionals treating these patients and meeting people living with rare diseases and their relatives as well, I would say.
Yes, network medicine is a new branch of medicine. It's a new science that is being grounded by Professor Joseph Lo Scalzo and Laszlo Barabasi at Harvard. And it is the application of a science that is called network analysis that use graph theory to medicine. So it can be seen, maybe you have heard system biology, then it became a system medicine. Now network medicine is a further, let's say, evolution of system medicine. The beauty of network medicine that the approach and network analysis is used everywhere. For instance, has been used by FBI after 9/11 to understand how the network of terrorists did act, and they realized that they were wrong in looking at the network. So they redone all the instruction for the FBI how to monitor these things. The beautiness is that you can represent reality in a complex way of interactions, and you can look at different layers of informations and integrate them in a very, let's say, complex way, but at the same time is in a way that very easily make you understand where is the interaction that is more important. And this, what I'm talking is not only, maybe you have heard about single gene polymorphism, genetic score. Of course, genetic score is better than a single score, but is far away from having the definition of talking about you or maybe the people that is in this room. But if I had, for instance, not only biological, my biochemistry, but my preferences in driving the car or taking the bus, or if I put in it, for instance, all your history of medicine that have been given to you, because that may be influenced more, then I can create a much more complex. And maybe you can see that because 2 years ago you had got a treatment with certain antibiotics has changed your system in a way that you are not anymore like you were before.
So, but in the word network medicine, to me it sounds like when Stephanie just showed that slide, very busy slides with all these interactions that some patients do have, or people living with rare diseases have with healthcare professionals and others, also in society, the system. How in practice, or
in practice,
to be concrete, how can your work support that?
I can show you some practical examples. We live in networks, so that kind of interaction, you were showing interaction in the system. Now, very nice, because we said all the, let's say, idea behind this meeting is to have the patients in focus. We, with network medicine, we describe from a mathematical point of view the patients in a new way. We don't see only one thing or the sum of different things. We see you as a whole, so that, and the fact that I can compare you as a unique person to her as a unique person, I can immediately look at the interaction that are in common and the one that are different, because those both give me information where I can distill practical information. For instance, in US, I don't want to do any commercial. There is a company using network medicine that has a tool in the market that they predict the efficiency of treatment with TNF-alpha inhibitors. So the doctor in the US now send the blood to this company. The company say, you have 20% of chance to respond, or you have 75% of chance to respond. That is up to you with your doctor to say, no, I don't want it because 20, I feel it is too low. Yes, let's go because of 75. These are, so with this application, you can create companion diagnostic, but also you can redefine a path in the hospitals or digital tools that predict the efficiency.
Would you like to, you had some slides. Would you like to show that in order to...
Yeah, if I... can come here. Because
give some more
yeah.
understanding to the audience of how this can be. I think you just click, it will.
No, yes, it was a little. So I'm not showing you any kind of mathematical functions. I spare it to you. These are my disclosure, and so this is me. And I always say why it's so difficult when I'm at work and see patients to apply the guideline, because actually the guideline does not talk about the patients that is in front of you. Talk about population, talk about trials. And I also ask, Will, now it's very popular genetic score because there is a lot of people that is doing it, old medicine, the old fashioned, but they change and they say to do personalized medicine. But it's just renaming an old approach to medicine. Because again, as I said before, a single genetic score is weak, a polygenetic score is stronger, but far away from describing the complexity. A very nice study, Mendelian randomization, is a fantastic tool to analyze population, but not to guide you really in treating one single patient, because in that case, that patients belong to two different quartiles. And if you look at the number, I have to go through almost like 5,000 patients to be sure that you, just you, belong there or there. It's impossible in real life. And you go, you know, here now we have a lot of technological possibilities. And we are maybe heard something called multi-omics, and very important, but we should try to do not multi-comics. And the problem is actually how we approach medicine. In the past, we used the conventional medicine was reductionism in practice. And it was important there because we need to find the cause of the disease. We need to find the cause of syphilis, and it was a bacteria. But now we are in a reality where there is no one cause. The one idea of one belong, religion and politics cannot belong to medicine. Because the limit is that the old way how we look medicine, that all patients that have the same diagnosis share the same pathophysiological mechanism. Or because you have an ICD-10 diagnosis, you get the medicine, everybody has to respond to the medicine the same way. And this is not true because, for instance, a statin that is very effective medicine have a number needed to treat of 57, meaning that in 56 patients doesn't work what it's supposed to do. So that problem is really now today is to go from a complicated, because the reductionistic approach is complicated. If you open a watch and you look at the mechanism, that is a complicated mechanism, but it's not complex, because when you move the part of the watch, they always give you the same response. Doesn't matter where you go. Complex is that you cannot really predict, because you have so many complicated interactions that there is a complexity there. And in the approach of network medicine, from going to complicated to complex, is that the patients are unique. We were discussing, we all are rare disease patients, because I'm unique. There is no other person that has my, we'll say, system. And also, we look, instead of doing, let's say, like a cake where you put all different layers, network medicine look at the interaction between the different layers to create a unique representation of the patients. I want to say here, you can say diet, habits, environmental, social. If you want here, you can put also your preferences in music. Or there are dimensions that has been never considered that can be integrated. Does the patient that listen Mozart 3 times a week respond better? Well, Paul would say it's bullshit. Nobody has yet investigated that. We have a complex model. So that here, in Sweden, what we did in my group, we tried to, instead of making layer of networks, to integrate everything in a one way. And we did a proof of concept where we took transcriptome, biomedical parameter. The biomedical parameter were the laboratory result of the hospital of the patients, and the methylome, how DNA is built. And we have integrated these data all together immediately. And what we have created in a study, this is the network representation of the response to a cholesterol, intestinal cholesterol sorption inhibitor that is called ezetimibe in the patients included in the study. As you can see, we integrate to each other. This is network analysis. And you can see here, there is C-peptide. Look at the centrality of C-peptide and how is connected. So when you look at this network, you look also the centrality and how it's connected. But can you implement this information in real life in the hospital? Not a chance. That's why when you create the other network and you look at what is unique, you decrease the dimensionality. And here we already identify 3 genes that affect cancer that were not known to be regulated by cholesterol synthesis inhibitor, cholesterol intestinal inhibitor. And we already tested, at least in vitro, that this is true. So, to be my work, I approached network medicine 5 years ago. As is a 5 years that we are in the fighting against the classical medicine, struggling to survive, because either 50% of the colleagues that they look at us, they don't understand what we are saying, or the one that understand what we are saying, they feel threatened. But what we are doing here, there are 2 consortium that I built up together with other colleagues, and there is Dr. Marius Gaenta there. In this consortium, there is FH Europe, that is one of the biggest Europeans. So here, NetMe now, we are working to implement this in Sweden. We are already in contact with Gothenburg, with Malmö, with Uppsala. And as you can see here, you have cardiometabolic disease that usually medicine divide them as an organ or in specialty. Here instead we want to integrate everything. And here also we want to integrate everything. This has been submitted now to EU to create a personal, patient-based, personalized.
Is this last? Yes.
Yes, this is the last to show you the network medicine is already a reality because I'm a part of a European consortium that is called RIPO. So I'm going to drive here in Sweden the first A-based network-based trial where we select patients that have resistant hypertension with network medicine and with AI to only identify the one that we are 100% sure that will respond to the new drug that has been repurposed. These drugs that we are going to use are drugs already on the market, and some of them don't even anymore patent on it. So it's a new approach to medicine.
Thank you. And you say new approach, and it's quite impressive and cool to watch this and to see this the setup. Is it already in practice? Can it already be connected? To go back to Stephanie's, to connect the 2 here, Stephanie's presentation of the needs for patients here in Sweden, for example, living with a rare disease, having up to 60 or 100 contacts.
Yes, what I say that since the founder of this branch of medicine were from US, Boston area, you already have a company that have developed, again, as I said, the companion diagnostic that they predict, because we want to go to mechanism-based treatment. But mechanism, don't think only the DNA or the molecule. You have to think all the person as a whole in lifestyle. So this is already a reality. For instance, we are now with this RIPO Hyper2 trial in a direct discussion with the Swedish medical agency because we are going to test a AI-based tool and we have, together with them, we see which is the legislation that we have to follow to implement this thing in. So being part of REPO for EU, and actually in 2 weeks we have the second international meeting here in Stockholm.
So
is already
to
here.
give the question back to Stephanie, trying to sort of connect you two, the needs, the concrete, the urgency of finding solutions. What are some of your reflections?
I mean, I really like the kind of more holistic approach that I see in this network medicine as you presented it, that you try to connect different systems and find the reason behind, the cause behind why people are getting sick. So, I mean, this is the first challenge, of course, in finding the right diagnosis. Because what I did not tell you about in our member survey, diagnostics is also a huge challenge, and to reach the correct diagnosis is one first hurdle that you face when you live with a rare disease. So looking at the whole picture and taking in all the data that you can get and putting it together would I see as a large advantage in finding a diagnosis quicker. And also then another challenge in rare diseases is of course we have got smaller patient groups, and if you find treatments then you will have a larger variability in this group because it's so little and it can vary a lot. And understanding why we see these variations could probably help very much to better identify the right cure for the right individual, or understand why we have lower outcome in some treatments as we would expect. So I think there's a lot of very interesting information in here and possibilities. So I would really look forward to follow this work.
And going back to one other more concrete solution, quite sad to see how few patients were even aware of that. They actually have a right, or they should have, or they have an individual treatment plan. Right. What do you think about how can that be improved?
I mean, I guess this was the result from when we ask our members, right? When we ask them, they say 20%, yes, we have an individual care plan. However, when we talk to healthcare professionals, they would tell us that, of course, everybody has a care plan. Otherwise, we cannot treat the individual, right? So I think there's a communication issue here that you really have to understand that if you are a person with such many healthcare contacts, no one from the healthcare system as of today has the mandate or the resources to provide you with the support that you need. So the result is that you have to try to hurdle it yourself. So you're the one with all the information, but then you also need to get all the information. So communicating back to the individual, this is why we treat you, this is how we treat you, this is how we plan to proceed, is really, really very important for especially our members. And I think this is a challenge also, that in the rush and in the very high-pressured healthcare system that we have of today, to get an understanding for that. I think this is very important.
So communication often comes back to that, both ways, and also using the knowledge and the research being done that you, for example, described here today.
Yeah, I like.
We're coming to the end of our session, actually. So, would you like to have? Do you have a final comment?
Yes, to what the colleague was saying, that sometimes when I see patients with rare disease, and they say the good thing is when you get your diagnosis and you identify the genetic defect, but if you meet the wrong healthcare, is the worst thing that can happen to you. Because they stop to look you as a person, they just look you as a genetic defect. And they don't understand what is going on, to what to say. So it's very important not only put the patients in the center, but describe the patients in a new way and create a new mindset in the healthcare person.
Stephanie, do you have a final comment on... apart from what you just mentioned about the need for increased communication, and in order both for speedier diagnose, the right treatment and care.
I mean, I think that the whole development towards and the speaking about more person-centered, patient-centered care is very promising from our point of view, that we have this insight that we need to listen to each other more, to see the whole individual, and to try together move towards shaping the system in the way that our vision in the healthcare system that we together formulated. So I really hope that this contributes to us getting there in the future.
Thank
I
you.
would say.
Thank you both, and thank you for
you.
listening in. The discussion around patient-centric care will continue all day. So this is the end of this session, and I believe there's a new session starting in a few minutes, actually, in this room. So thank you to Stephanie and Paolo.